after hospital, but I was very impressed by the care shown by Katie, wrote Nicholas. This patient was not easy. He had declined several places for various reasons, and he was going to be leaving the hospital that day one way or the other. But he did not have to sleep on the streets. Sorry about the background noise. So Nicholas wrote, this was a bit of a revelation for me. Often as juniors, we work according to protocol and have very little scope for varying practice. But this has reminded me that there are always going to be situations that the protocols don't cover or are just plain wrong. Situations where there is no ideal answer. You have to try and be a decent and caring person, make the right choices that feel right after careful thought. And though you may not be correct, you will at least have done your best. I certainly feel that this example was a good reminder for me to always at least try to achieve a better outcome for a patient, even if it may make objectively little difference from an administrative point of view. Katie, you're an absolute star. Thank you so much for going the extra mile. A big round of applause to Katie. Humbles me, Katie, humbles me. Then the team of the month, the lung cancer practitioner team, dominated by Steph Morley. The lung practitioner team have recognised the importance and positive impact that input from the allied health professionals team can have for their lung cancer patients, and the long-term effects this can have on their patient cancer journey and experience. They have demonstrated a willingness beyond expected to accept the changes and opportunities this new team can offer, and have been instrumental in the reintroduction of the OCS programme. They are providing advice and information to cancer patients at an early stage, impacting their care at all points after this, and ensuring patients receive the best possible support in a difficult period. Guys, you're absolute stars. Thank you so much. You are our Going the Extra Mile Award team winners. Thank you.
Thank you.
And then we had a lovely letter come in to the board from Ryan. So, David, do you just want to read this out for me or edit it out appropriately?
Yeah, sure, Russell. I received this from Dr. O'Leary, one of our consultant anaesthetists and ITU consultants, and I've edited it slightly to preserve the patient's confidentiality, but he says, I'm not sure if either of you are aware of the critically unwell patient who suffered cardiac arrest twice in ED recently. I feel that the care provided is worthy of recognition. The young patient, and this patient really was young, holidaying Herefordshire, presented to ED with signs and symptoms suggestive of a massive pulmonary embolus. That's a clot on the lung. We, the ITU staff, were asked to attend when suddenly this patient deteriorated. We found them in a state of cardiovascular and respiratory collapse. They were far too unstable to transport the short distance to CT, and so was thrombolyzed on clinical grounds, and after a scan of the heart performed at the bedside. The patient's heart stopped twice during the thrombolysis. That's the clot busting process with the drug, but was started again by the team. It stopped again, and again the heart was started. After this, they were transferred to ITU with an overnight management plan to try and stabilize them and provide support to both their kidneys and heart. When I returned to the unit in the morning, having left late the previous evening, the patient was stable and had woken with no obvious damage to their brain. They were referred and then transferred to the Queen Elizabeth Hospital in Birmingham for ECMO. This is a system that replaces the function of the heart and lungs while the patient's own lungs are not up to the task. CT confirmed the diagnosis made clinically at Hereford. The patient, I'm glad to say, is now off ECMO and continues to improve. Various teams at the QE have been incredibly impressed with the treatment and care provided in Hereford. I can very safely say that if it were not for the exemplary and professional treatment provided by all our teams at all stages during this patient stay in Hereford, they would not be alive today. There are various people who have contributed significantly to the patient's so far positive outcome, and I'm sure to miss some of them off the list. However, special praise and mention should be given to the ED nurses and doctors on duty that evening. Ryan's registrar, Doctors Graham and Sravinas, trainee ITU ACCP Emma Griffiths, consultant anaesthetist Duncan Cochrane, the cardiology registrar Dr. Ahmed, who performed the crucial bedside scan, Doctors Prasad and French, both our consultant cardiologists, ICU nurses Jennifer Austwick, Jane Beaumont, Tracy Hamer, Sarah Anderson, Meg Phillips, Jen Glover, Sarah Bright, and Becky Stone. Ryan apologises for those nurses he's inevitably missed off this list. He goes on to say it's very rare for Hereford to have a level 4 patient. That's need a patient so ill they need 2 ITU nurses. The patient received absolutely fantastic nursing care from the moment they arrived on ICU to the moment they left with the transfer team. He'd like to thank the ward clerks, housekeepers and HCAs, the West Midlands critical care team that took the patient to the QE, Doctors Upal, Doctors Ford and Dudley, and lastly those doctors at the QE, Doctors Lim and Richardson and Dr. Shahan, who coordinated the transfer. And that's it. Thanks, Russell.
No, thank you, David, and team. Everyone mentioned there, absolutely phenomenal efforts to save a young person's life. Thank you so much, and I'm sure the family in particular will be so grateful for the competence and commitment you showed, and it's a wonderful example. And I know, David, you've sort of sent that message back. So big round of applause to all of our Going the Extra Mile heroes today, guys. You're very welcome to stay with us if you want to for this board meeting, but we'll understand if you want to do other things. So on to the board. Any new declarations of interest? Please raise a digital hand. Okie dokie. So last set of minutes held on the 1st of September. Was everyone happy with the accuracy of those? If you want any amends, please raise a digital hand. Okay, can't see any hands raised, so I'll take them as an accurate record and duly sign them. So on page 18 of our pack, we have the action points arising, so we'll just run through those. The first was on quality, where Jane and Lucy would discuss the time frame agreed in response to complainants to ensure we have data around the availability of the next board meeting. The process has been changed, Jane, to make sure that happens?
Yeah, next time it comes back, it'll be against a new metric.
Super, thank you. And then Jeffrey will ensure the reduction in appraisal rates is discussed at the next F&P meetings. Thank you, Jeffrey, for doing that. And then Jeffrey will also include in his report details around improvements about retire and return. Look forward to talking about that a bit later, Jeffrey, but thank you. On freedom to speak up, we had a session on freedom to speak up for members of the public to be aware of this morning with Denise, and thanks to Denise for all of her hard work and best wishes for the future. But it will include an update on the number of staff receiving feedback following raising issues, and we will do that, won't we, Jeffrey? Thank you. And then the Associate Chief Nursing Officer Surgery Division will discuss the issues around falls prevention with the Clinical Manager Physiotherapy, Inpatients and Community Services to see if there are any new technology available to support in this area. And she's suggesting that it's part of the Falls Awareness Week discussion, and wondered if a NED safety walkabout during Falls Weeks too. I think that's a fantastic idea. Lucy, anything you'd like to add?
Yeah, we missed the boat on the Fall Safety Week, I'm afraid, but I'm very happy to support any NED walkabout with a focus on falls, and then we can start to just discuss the technology that's associated with falls prevention. So very happy to arrange that for any NED that would like that.
Okay, that's great. Just as a matter of interest, does anyone know how many wheelchairs we have on site? Okay, just as an action point, can we pop down how many wheelchairs do we have on site? Just because I'm picking up in different forum about falls risk as due to a lack of wheelchairs. Okie dokie, so we'll move on then. If there are any matters arising that you think I've missed, please raise a digital hand. So we're on then to the highlight of the Wye Valley Board meetings, which is Glenn Burley's Chief Executive report. So Glenn, over to you.
Not sure it is. I think we started with the highlight, didn't we, Chair, today? So, and congratulations to our execs for not trying to guess the answer to the how many wheelchairs are on the site question. I'm just going to pull out some highlights from the report, if I may. Firstly, I'll start with our new Secretary of State, our fourth in 18 months, setting out what's described as our plan for patients. This was released last week. It pulls together, to an extent, a number of existing commitments that were captured in other documents, particularly the winter plan, but also gives an indication of some of her priorities, including on that first page, the focus on primary care and primary care access. And what it states is that individuals will be able to, or anyone will be able to have an appointment within 2 weeks with a GP, and if they're urgent, on the same day. And it sets out how additional capacity we put on stream to help with that. I mean, the challenge for our primary care colleagues will be making sure we have the workforce available to meet that need. Although I would suggest that our local GP access is probably already meeting those standards from what I understand. But it will be a challenge for many parts of the NHS, so it's something that will be monitored closely over this winter, and you can see within that plan that integrated care boards are being asked to keep particular oversight on that access. She then also uses the ABCD priority, so A being ambulances, and this looks at the particular problem of handover delays. I mentioned before, I get an hourly update on those, and today's performance is showing again ambulances waiting for over 12 hours outside some A&Es not far from here. And this is going to be a really important focus over the winter, and we'll come back to this when we talk about the performance report and some of the things that we're doing locally. Backlogs is the B, the 7 million people on the waiting list, many of whom are not waiting for inpatient treatment. Many of those are outpatient activity, but a need obviously to address that over what will be a difficult winter. And it sets out some of the investment around community diagnostic centres, some of the investment that's gone into improving waiting list performance. In fact, tomorrow I'm in a session looking at how we're going to manage this over the second half of this year, which I'm sure Katie will want to hear how that's going to work financially when I come out of that session. C for care, and this is where there was a new announcement around the £500 million being made available to support the Adult Social Care Discharge Fund. The feedback we're having on this, and thanks to Jane for joining the National Task Force yesterday on my behalf, is that this is probably likely to be Better Care Fund rooted. Again, the challenge will not so much be the money, it will be the workforce to spend that money on. But we do need to ensure that we have a suitable flow of patients out of hospital over this winter particularly. And then the D stands for doctors and dentists, and there's quite a focus there particularly on access to NHS dentistry, which is a problem in many parts of the country. And what they're seeking to do with some of these policy changes is ensure that we can improve the workforce situation by removing some of the barriers. I then move on in my report to talk about trust and group strategy refresh. We had a great session of the board a couple of weeks ago now, looking at this from a Wye Valley perspective, and it was a useful session just to take stock of that strategic wheel diagram, which is there in the report, which has been our guiding light for a number of years now. And having gone through all three of those workshops now, all three trusts are pretty much saying that is still a very relevant strategy. But what we will seek to do is to accelerate some of the work, particularly around integration and prevention, through a series of what we're calling big moves that we're developing in the background, and we'll bring that into a public board meeting soon. There's been quite a lot of stakeholder and staff engagement in the process in all three organisations. The annual general meeting took place on the 22nd of September. Great AGM, actually, particularly in the context of all of the pressures that we faced over the last year. There was some really great service developments also. And for those of you who missed it, if you could go to our website, there's some fantastic videos that show just an example of some of the things that we did and managed to deliver over the last year. And then on to our great team, so the Integrated Care Division update. We spent some time this morning looking a little bit at what's going on around primary care networks. The post that we have in collaboration with our local GPs that ensures that we have joined up community services and primary care staff is absolutely leading edge on implementing the fuller stock take, in my view. And so it's great to hear about how that's developing, so that we've got just a one workforce approach to the challenges that we face. I won't go through all of the things that are in here because there are many, but it's great to see the expansion in frailty and the frailty consultant appointments. The ward discharge coordinators are also going to play a really important role over this winter in making sure that we achieve the best flow that we can. And whilst it's good to have those discharge coordinators, it's everyone's responsibility to get patients home, and that's very much the culture that we'll promote. And then finally, the individual and team going the extra mile awards that we celebrated at the start of the meeting. So I'm happy to take any questions, Chair.
Thank you, Glenn. Very comprehensive as ever, and thank you for your hard work. Questions and perspectives to Glenn, please raise a digital hand. Okay, so I think that was all very clear. Oh, Francis has raised a hand.
Thank you, Glenn. Very clear. And it will be a theme throughout, and as we move into the integrated performance report. But echoing some of the things in the new Secretary of State's ambitions, I think that the pressure that the system is under shouldn't be underestimated by anybody, and our staff are working in extraordinary circumstances to do the very best they can for the people of Herefordshire. So we are, it is about partnership, and we're very keen to support patients and their families and communities to help us to help them, and asking for forbearance with that, really, because we share the ambition to tackle the backlog as well as meeting the people who need immediate care on the day. So just really support for Jane and the rest of the executive team and all of our staff. We understand how tough it is. It feels like the middle of winter, and in my book it says it's the beginning of October, so it does feel unprecedented in terms of how many people are needing our care and support.
Well said, Francis. And Grace, and then we'll move on.
Thank you, Chair. Very much echoing what Francis has said very, very beautifully. Just a quick question, Glenn. In terms of the aspect from the new Secretary of Health Social Care about informing patients by publishing data on how many appointments each GP does and the length of waits to enable patient choice. Maybe I'm just being really dim. How will that enable patient choice? Like, would you pick a GP because you're like, oh, they go quicker? And I don't know if that will take into account the complexity of appointment time and uptake and socioeconomic disadvantaged areas, because there's going to be a big difference between, like a new housing estate of young professionals and where I live, which has a lot of disabled people in a council estate with a lot more difficulty there. I think it's a good question. I can't get inside the Secretary of State's mind, but actually, remember, all the evidence shows that if you measure things, then you tend to understand the variation. I think one of her big themes is the amount of variation in the NHS, and one thing that we've never actually measured in the NHS is the amount of patient contact in primary care. So the number of appointments that take place in primary care, it's a relatively new measure. So I think measuring that and seeing what the access times are, firstly, might help the public to understand that they can access their GP quite rapidly if they need to, because some of this is based on a myth that they can't and they go straight to A&E.
but others might be to ask their individual practices through, and many of them have, well, they all have patient engagement groups. If they're off the pace in terms of access compared to other peers, as to what they could do to improve that. So I think the use of data on this will be helpful. But I say that a lot of it, I think, will demonstrate that primary care is doing a better job than many people think.
Okay, team, thank you for the questions, and Glenn for the answers. So we'll move on then to the detail of how we're doing on the integrated performance report. What highlights and lowlights would you like to pull out, Jo?
Yeah, a couple of main things I want to talk about, but I just wanted to pick up Francis' point about the importance of delivering on our elective plan. And Andy and I were sent a few days ago, actually, the regional benchmarks on how we're doing really against that 1920 plan. And actually, for the last 2 weeks, we've been in the top 3 in the region in terms of delivering against that sort of activity baseline of 1920. So we're actually doing really well against that, not quite as well as we ambitiously set out, but we are doing really well against that, and that is particularly impressive given the challenges that we have in urgent care. Every now and then I go and irritate one of our members of staff by going and shadowing them for the day, and so yesterday happened to be I was shadowing one of the junior doctors on the acute medical take from yesterday morning till just after lunchtime. And it's always just a privilege to do, and you learned a huge amount. And I can say, the staff were, in really difficult circumstances. It was mainly in A&E. The staff are just excellent and compassionate and working in really difficult circumstances. But just 2 examples to pull out of that for how difficult it is. He had the next patient to see, and then it took him 10 minutes to find a cubicle to see the patient in. So it just slows everything down. At one point, he made me guard a cubicle because there was a patient coming out, so that he could nip in and be the next doctor to see his patient in that cubicle. And that's not great working conditions, and it's not great patient care. The other thing I saw when I was there was a young chap in his 40s who'd had a heart attack in the night, and he'd phoned an ambulance, and they'd said it'll be 3 hours. So he managed to phone his brother-in-law, who'd got a car, who could bring him into hospital. These are dangerous times for our patients, and a lot of pressure on our staff. So one of the things that we've done this week is we've put in place what's called a proactive boarding policy. It's something which Andy's been looking at for a few weeks, actually. The region have now suggested it's something that everybody should do as a matter of course, but we haven't been looking at it for a few weeks and engaging with staff. But what that really means is that we know we'll have a number of discharges during the day, and often they're quite late in the day on our wards. And actually, on the basis of the number of discharges we're expecting, we'll start to move the patients out of that front door into the ward. So that means at times wards are going to have more patients than they've got beds for, but it'll reduce the pressure a little bit and reduce the risk a little bit at the front door, and it'll increase the pressure and the risk a little bit on the ward. So that's what that means, and it is very much the least worst option that we've got. It's not a good option, but broadly it's probably increased our bed capacity during the day by about 25 beds or so. But all of this, this is what we're sort of reaping, I think, after nationally there's been a real lack of workforce planning, funding and planning for a workforce that's big enough in health and social care, and we have reached that tipping point. The NHS and social care has reached that tipping point. So we are doing things which I don't think we'd have previously thought were acceptable, and that might not be the end of it. So in terms of workforce and recruitment and retention, then what are the things we're doing? So we've had some good news this week. So 44 of our international nurses have passed their OSCE exams this week. So absolutely brilliant for the teams who support them, because they get them through with really high levels of success in their exams all of the time. So that's quite a big group of staff who are going to come into our teams. And then the other thing is we've got a business case later on the agenda, and really this is pulling together two things really. One, our ambition to grow our own staff and to make sure that we've got really good career pathways for our healthcare support workers, so we can help them to go through into registered nurses or therapists. But also around how we support our staff with cost of living, because we've got 20% healthcare support worker vacancies. We turn over about 20% every year. I mean, those aren't figures that 5 years ago we would have been looking at. This is a workforce we've always been able to recruit to well, and now we can't, because the paying conditions are so much lower than they can get in other parts of the economy for much less difficult and taxing work. So I'm hoping that we're going to approve that later, because I think it's really quite a big shift in how we recognise, train, support and reward that really important workforce that's at the bedrock of everything that we do. So hopefully we'll approve that later. But I guess it's a response to both of those things. As I say, the lack of workforce planning that we've been subject to, but also how we deal with some of the cost of living things that are going on at the moment.
Very comprehensive and well said. Thank you, Jane. Questions and perspectives, just keeping the pace going, Glenn?
Yeah, can I just talk a little bit more about the proactive boarding policy? As Jane says in her report, it is guidance from region that we do that on a proactive basis. What we need to ensure in our organisation, I've said this in all three boards, is that we look at risk ourselves and support clinical judgment as well alongside such policies, because there will be moments where that won't be the right thing to do, and we need to support our staff in doing that. I think it's a good approach for us to get into that discipline now, but when hopefully we're in a better place, we need to review that and see whether there are other solutions. The best solution is for the beds to be ready because the patients have been discharged appropriately, rather than a kind of forced scenario. But over this winter, we will just have to manage system risk as well as the risk to overall individual patients. So that's something we just need to keep a very close eye on and do what we know is right locally.
No, absolutely, Ken, well said. And Ian, then we'll move on.
Yeah, first of all, I wanted to say, Jane, how helpful it is actually in this report that actually you start by highlighting our 4 priorities: recruitment and retention, emergency flow, productivity and backlogs, and patient experience. And then actually it really helps, I think, focus attention in those areas, and particularly as we know when actually we work in an NHS where everything's a priority. So just really helpful to have that, and certainly in the context of a public board report, helpful, I think, for that message to be the one that we're communicating. So I find that really helpful. And secondly, just to acknowledge your very powerful paragraph in there about the pressures that staff are under, and you use the phrase moral distress there, and I think, and these are very, very fraught decisions that are having to be taken kind of day by day, hour by hour, and clearly we're supporting our staff to do that. But I think it's important that the board is acknowledging that and saying actually we are supporting staff to make those difficult decisions. And my final point in that regard is there's a public dimension to that as well. I'm just conscious the public will be, in a sense, they'll experience this. They'll be coming to the hospital every day. They will see the consequences of what we're needing to do. And I think there is something we need to think about, which is about how we communicate with the public about what we're doing and why we're needing to do it.
All points very well made, Ian, and thank you for making them. And again, just to reiterate our total support as a board to the difficult decisions that frontline colleagues have to make on a daily basis, and the risk assessments that they need to make. Jane, anything you wanted to say in reply to him?
No, thanks, Ian. You're right about the communications part of that. And I think some of this is around how staff explain to patients as they come onto ward where they're really. I mean, our A&E staff are already very expert at explaining, and people can see. But I think the point's really well made that particularly our senior nurses on the wards need to explain to those patients coming through about why there's more patients than there are beds.
Okay, great. So we'll move on then to quality and safety, and Lucy and then David.
Yeah, So I just want to talk about infection prevention and control, if I may, very briefly, and then I'll hand over to David for mortality. So just in the introduction of the quality section of the report, we refer to an increasing number of outbreaks of COVID-19, particularly in our community hospitals and on some of our acute wards. And we are seeing an increasing number of COVID-19 cases, largely being driven by the outbreaks, but also about in relation to the national easing of restrictions more recently. What we know about the COVID-19 is that it's still extremely contagious, which is why we're seeing increasing numbers, particularly at times of outbreaks. But positively, we're not seeing that significant illness that we saw early on in the pandemic. It's not in the report, but I think it's worth mentioning. Within the Midlands, we're seeing an increasing number of flu A cases. Hereford is normally one to 2 weeks behind that, so we're expecting flu A here sometime soon. And therefore, I would just use this as an opportunity to say that when you're invited to have your COVID-19 booster or your flu vaccination, you should certainly take up that opportunity. And we've been running our flu and COVID-19 booster vaccination programme for our staff successfully during the last month and have had a really great uptake. Part of the report just covers the Clostridioid infection outlier status that we have, and it makes reference to the fact that our inspection from NHSI was deferred due to Her Majesty the Queen's funeral, but we've now had the date confirmed and they'll re-inspect us on the 25th of October. 2 colleagues from NHS Improvement are coming from our infection prevention team, and they're going to be joined by public health colleagues. We've shared with them in advance of the visit our quality improvement plan associated with Clostridioid infection, and they're satisfied that that includes all of the elements that they would expect it to include. But what I'm really pleased to report before I hand over to David is that 2 elements of our battle with Clostridioid infections is around antimicrobial stewardship. And I'm really pleased to say that we have supported the funding for an antimicrobial pharmacist. And although we're having difficulty in recruiting pharmacists, we do believe this role is really exciting and will successfully recruit into that. And then the other element is that as of next week, we'll be rolling out antibiotic ward rounds with a consultant microbiologist participating in those. And we truly believe that those 2 things will help us reduce Clostridioid infection. I'm happy to take any questions now or hand over to David, and then questions at the end, Russell, whichever you would prefer to do.
Thank you, Lucy. Let's continue with David and then have questions at the end. David.
Thanks, Russell. As you recall, I registered with the board my concern a few months ago about our increasing mortality statistics. I think you can see that we've got a stable situation now. In fact, we've seen some, with the eye of faith, some improvement, especially among our HMSR. We're actually the lowest among the group. Shimmy, we are mid-range. Down the right-hand side is our slightly different approach to our increasing mortality that we'd previously seen than we had used in the past. So specifically around the out-of-hospital deaths, which are the ones that have put our figures up. Our in-hospital, both figures are right on the average, actually. We're using Yeovil as a representative trust who has a very much lower HMSR and Shimmy. We start to get some interesting data there. Their in-hospital deaths are just, well, their statistics for in-hospital deaths are just the same as ours. It's just they don't appear to have the out-of-hospital deaths that we have. So we're analysing that a little bit. And I think that's probably all I want to say, Russell, unless anyone's got any questions.
Okay, that's great. Any questions to Lucy or David on quality and safety? Andrew?
Yeah, it's just a question on page 27. It's to do with the action plans and not meeting the deadlines. And I suppose my question is, are you concerned about that? That's the paragraph in the middle there. 19 actions were set for completion. It's sometimes we see this in audit committee as well, that people commit to actions sometimes which they were never going to meet because of external factors, But yeah, I just suppose, are you concerned that there's any issues there in terms of people not actually doing their best to meet those targets?
Lucy?
Yeah, so we review the action plans in detail at the Infection Prevention Committee that meets once a month. And whilst, some of the actions have slipped because of the pressures on the infection prevention control team. So they're a small team of individuals who have to respond to things such as outbreaks and other matters. But there are none of those actions that have slipped that would have a negative impact on whether we can aim to reduce Clostridial infection or not. So none of them have a significant consequence, if that makes sense, on Andrew. It's more around some of the communication and publicising schemes that we want to take forward for awareness and educational purposes with our teams.
I think just culturally, though, Andrew's quite right. We want to avoid a culture where missing deadlines is regarded as just the way we do things. And I know that's not what you're saying, Lucy. And Grace, and then we'll move on.
Thank you, Chair. Thanks, Lucy, for the report. I just wanted to check, in terms of page 28 and the patient complaint times, I know we're going to come to this later, so perhaps that's for then. Is there any sense of why we're not getting traction on it, or anything that patients would like to have happen during delays if they can't have the answer really quickly due to the complexity? Is there anything that is needed to happen in the meantime that we're aware of?
That's up in the patient experience report, Chair and Grace, if that's okay, and then
Of course, Lucy, we'll come back to it, but thank you, Grace. Okay, we'll move on then to Andy's update on how he's seeing things from the Chief Operating Officer's perspective. Andy?
Thank you, Chair. Just a few points to raise, already been mentioned, but obviously our urgent and emergency care pathways under significant pressure, and the teams remain focused on reducing our long waits for admissions, easing congestion and reducing ambulance handover delays. Jane's already mentioned our enabling proactive flow procedure and how we've implemented that, but that will be a tool in our arsenal as we head in towards the winter period. We're just working on our surge plan and escalation plans for the trust, and finalising through consultation at Trust Management Board what those options will be to allow our operational and clinical teams to create capacity as we move into what is potentially a challenging winter, and protecting our elective activity for as long as possible to ensure our long waiting patients get treated. Glenn mentioned our discharge coordinators, and we're at the end of our 100-day discharge challenge across Herefordshire, and we're evaluating our plans and producing our next steps on our action plan, linking in with social care and their high impact change model. Obviously, Glenn mentioned we've got our discharge coordinators, we've got 4 currently. The remaining posts are filled by the end of the month, and they will be a key element to starting the discharge planning process at the start of the pathway at the front door on our acute floor, and they'll be present at our board rounds and MDTs on each ward to support the teams and discuss and progress patient pathways. Other actions in that 100-day challenge is we're undertaking a demanding capacity planning with our community ACPs and our hospital home team, and working with social care about our capacity in our discharge to assess capacity. Also in development with Connor Price, our Foundations Group Information Lead, is the system discharge dashboard, which will show us a live demanding capacity across the system from medically fit our community and acute sites to capacity available in health and social care. One of the other challenges we face is cancer. Our 28-day performance and 62-day performance is nowhere near where we would like it to be. Our 28-day performances are particularly challenged at the moment. The main issues there are increase in our cancer referrals, 25% up year to date so far compared to 1920, with a particular increase in lower and upper GI that average 120% increase on 1920. Main issues there is our endoscopy capacity, some of the workforce absences and vacancies we've got, leading to difficulties in the backfilling some of our weekday sessions. Some of the plans we got in place is in increasing our nurse endoscopists, and we've also increased some of the PAs for some of our endoscopists to undertake more activity, as well as increase weekend working. We're also increasing our CTC capacity, and that's increased during September. So that was previously a major issue, but that will be mitigated as we go into October. There are also some process delays that myself and the cancer manager are working with the teams, operational and clinical teams, and there are some themes there. And with the recruitment of our MDT and cancer trackers, they should reduce over as we move forward. Already in the last week, we've seen our 63+ day cancer patients go from 200 reduced to 150. So already seeing real dividends in some real deep dives in some of our cancer pathways, particularly some of the process and admin delays that we're able to address. And finally, I just wanted to pick up on our stroke SNAP performance. SNAP grade B, that's the 4th quarter in a row. So it's 1 year of maintaining a SNAP grade B performance. And we're one of 2 top trusts in the region to achieve that standard, which is again a credit to the team.
Now, quite a phenomenal performance on stroke and SNAP. So please send out thanks to the frontline teams. Questions and perspectives to Andy? Very comprehensive update. Thank you, Andy. We know that the pressure, not just the frontline teams are under, but your teams are as well. Jane?
Just a bit extra on stroke, really. I've asked the team if we can get it to really look at what our outcomes on stroke are, because to say we've been punching above our weight for a little while now in terms of delivering the inputs really well. So we really just need to try and get underneath and understand, and particularly for those patients who get to us early enough. I mean, there's a group of patients that don't get to us quickly enough to have thrombolysis and so forth. But for those who do get to us early enough, so in a sense, we manage the whole pathway for them and meet all of those standards pretty much. We need to understand what the outcomes are like for those patients, because if all of that is right and the standards are right, we should be seeing some better outcomes. So I have asked the team to have a look at that, and it'd be something good to come back when we've got it.
Okay, that's great. Thank you, Jane. Please keep us briefed on that. Any other questions or perspectives from colleagues? Okay, members of the public and we as a board are certainly aware that one of the key issues we face is workforce availability. So Jeffrey, over to you on our people update, please.
Yeah, thanks, Russell. Well, with all the significant challenges faced by the workforce, we still ensure that the health and well-being of our staff remains a prime objective for the trust. So the HR department continues to support and coach managers in terms of making sure that we address sickness absence in a fair but also compassionate way. Our health and well-being continues to be at the center of our practice, and this week is our annual Health and Wellbeing Week, where we are running a series of wellbeing events for staff, and it's going down really well. So we are supported in that by some external partners, as I mentioned previously, and it's going pretty well. In terms of the clinical vacancies, we are expanding our international recruitment program and working with ICS colleagues as well, and as well as group colleagues on recruitment and retention incentives that we could put in place to try and support, obviously, staff turnover and reduce the vacancies that we have. Jane mentioned the new career and pay progression framework for healthcare support workers. We believe that would have a significant impact on that level of staff. With our admin staff, we are using the apprenticeship levy to try and expand on their development and training as well within the trust. With this month being Black History Month and also the Freedom to Speak Up Month, we are promoting our zero tolerance approach to any form of discrimination across the board. And we are also highlighting the benefits of speaking up and giving people the courage to call things out and to stand up strong, in the understanding that they would have no consequences or no repercussions. So we're just trying to promote that message as well. To do with retire and return, we have been working with our colleagues across the group, and we've refreshed our guidance and information, which has now gone out to staff. We will also start running quarterly seminars on retirements and pensions, because that's something that will be very useful for our staff. So we're just finalizing those plans, and we'll start putting those quarterly sessions in place for staff. I mean, ultimately, it's about supporting staff. It's about creating a compassionate environment where staff can flourish, go above the call of duty, and that is how we will make sure that we are also addressing productivity. So those are the key highlights from our report, Chair. Happy to take any questions.
No, thank you, Jeffrey. Just before I open it up, I mean, one of the great things for staff who are considering retiring is if you return, not only can you have the benefits of a more flexible way of working, but you can also earn a bit more money, which, given the cost of living crisis, is a practical challenge for many, we know at the moment. So there are significant opportunities if you retire and return. And it is our desire to make sure that's as easy as possible. Jeffrey, on any new communication that's going out on retire and return, could you make sure I see a copy, please? I'd be interested. So questions and perspectives to Jeffrey. Jane first.
Just to note, really, we've been waiting and hoping that the dial's going to move on some of these metrics for a long time. And Jeffrey, team, everybody's been working really hard at this. And this is the first time, I think in 18 months, we've had a reduction in our number of vacancies and a reduction in our turnover rate. So, you know, one data point doesn't make a trend, but it's really good to see that actually starting to go in the other direction. So fingers crossed it is going to end up being a trend.
Absolutely, Joe. And Glenn?
One thing I mentioned in my Chief Exec's report earlier is announcements last week of some more flexibility around pension recycling, particularly for our senior clinical staff. So I have asked the national team for a bit more guidance on that, because I think it does need to be applied consistently across the NHS, but that will help, hopefully, with encouraging individuals to stay with us rather than leaving for those tax reasons, which some of them sadly have. Yeah,
no, absolutely. And I think the change in IR35 legislation, which I understand is coming in next year, should also help. Okay, team. Thank you, Jeffrey. Continue to keep us briefed. As Jane said, fingers crossed this is a turning point, as they say, if you're a statistician. And we'll move on into the numbers. Obviously make David laugh. We'll move on then to Katie. Katie, over to you on the numbers.
Thank you, Chair. So this is the financial position at the end of August, so month 5 of the financial year. And I think the headline summary would be, despite all of the pressures that we've just talked through in terms of the overall organisation and what we're experiencing, actually from a financial perspective, we're only marginally at this point in the year off where we expected to be. So whilst clearly it's not the right side of the plan and where we'd want it to be, the pressures that we're experiencing aren't at this point having a materially adverse impact on our financial numbers. We know that the second half of the year will be more challenging, so our productivity and cost improvement plans are scheduled and planned to deliver more in the second half of the year. And we know that there remains uncertainty around the elective recovery fund mechanism, maybe pending Glenn's meeting tomorrow, but at the moment there's still some risk around that in terms of H2. What we are doing at this point in the year is undertaking a mid-year review this month, so locally within Wye Valley, but also across the system, really just to take that sort of stock check, temperature check view of some of those risks that we know about on the financial side, and see what that means in terms of the forward look through to the year end and into next financial year. In terms of the 3 areas of focus that we touch on each month, so agency spend does remain at a similar level to that we've seen over recent months, a slight uptick in August, and remains at around 12 to 13% of the pay bill. It is above the nationally set agency ceiling, but those actions that we've started to put in place around re-establishing our nurse and medical agency reduction programmes and the new contract with the master vendor are showing some early green shoots of improvement as we look into September and thereafter. So continued focus on tackling agency spend at pace. From a cost improvement perspective, we've delivered £3 million of savings to date. The risk adjusted forecast stands at about £7.5 million. That is still a gap in relation to the overall plan that we've set and the target we need to achieve. So we are continuing to drive at further opportunities to close that gap, and that will form part of that mid-year review process. In terms of productivity, we've got good oversight through Productivity Board and Trust Management Board, and a number of strands of work and some evidence of some delivery and success around productivity. So in standardising our theatre session length and revising some of the clinic templates. What we're working on now is how we review the financial quantification of those improvements and continue to build on the success we've seen over recent weeks at standing up more elective activity. Capital, we've spent £2.2 million year to date, and we continue to manage that challenging funding level, and our cash balances remain stable. In terms of cash, just to note on the Better Payment Practice Code performance, following a review with our external auditors of the calculation methodology, we have made an adjustment to that methodology to ensure it remains in line and consistent with national guidance, which has meant we've seen a dip in performance as we've applied that adjustment. We are expecting that to continue to improve going forwards, but that just explains the larger than normal dip from 1 month to the next. Happy to take any questions.
Very clear as ever, Katie. Thank you. Questions and perspectives to Katie. Ian?
Yeah, thanks, Katie. Very clear and a creditable position given the pressures we're under. Just wanted to reflect a little bit on the agency spend, which is obviously not anywhere near where we would want it to be. We've got good news in terms of nurse recruitment, and there are other things we're looking at around healthcare support worker career progression later, which in a sense is where we need to get to in terms of the underlying issues. I just wonder whether or not, or is it too early to say yet, how those two things start to intersect, and are we able to predict what we think the impact will be on our agency spend and our financial position towards the end of the year?
Yeah, really good question, Ian, and that's exactly what the mid-year review will start to tell us. So we'll have to make a series of assumptions around that. The plan already had a series of assumptions around international nurse recruitment, for example, and the timing at which we would have those nurses arriving and that they would pass their exams. So we'll logic check whether that's still on track or whether there's any variation to that, but it will feed through in the forecast.
Thank you, Ian and Katie, and then Andrew, and then we'll move on.
Yeah, on the agency issue, it would be good just to touch on the medical agency. It's quite a significant upward shift this year on last year, and just a reflection really. I think getting some certainty around the elective recovery fund would probably be more helpful this year than having a cost per case arrangement.
Thanks, Andrew. I mean, in terms of the medical agency, we had quite a lengthy session at execs earlier this week looking at some of the controls around medical agency and really getting under the hood as part of some sort of deep dive into which areas are we using it, are there alternative options, are we progressing recruitment activities quickly enough? And there are a number of these that are in really hard to recruit areas where we've tried multiple times and have limited other options, but we're certainly turning the stone on each and every one of them and strengthening some areas of visibility and control, which we'd hope would make a difference.
Okay, important that we see progress on the whole agency issue, which we're aware of. Ian, I assume that's a legacy hand. Thank you, Katie. Just remind me, Katie, how much cash are we sitting on?
It was about £29 million at the end of the month, Russell.
So hopefully there's a little bit of a CPIP opportunity on interest there. We'll move on then to some items for approval. If we can try and pick up the pace a bit, guys, just given the time. The first is the standing orders and standing financial instructions. Katie?
Yep, thank you, Chair. So the revised or proposed revised SFIs and standing orders are included in the pack. We've left track changes so that it's easier for people to see where we've proposed amendments. This is a refresh rather than a complete rewrite, largely picking up areas that required clarification that we've picked up in year based on queries, and to align financial approval levels across the group, which is a piece of work we've been doing through the shared service arrangement. These went through audit committee and were endorsed, and that's reflected in the audit committee report on today's agenda. One change was discussed at audit committee around further clarity in terms of total value and application of the SFIs, which we've now made, and so board are asked to approve. In terms of what then would happen, the intention would be to cascade directly to those who have delegated budget authority, and also to provide an offer of training and support to ensure that colleagues across the organisation understand their responsibilities in this regard.
That's great, thank you, Katie. Andrew, as chair of audit committee, can you just confirm you're happy with these?
Yeah, we were happy with them. We felt that there were some key and helpful improvements to financial controls in them.
Okay, super. Thank you, Katie. Any questions on these? This refresh of the standing orders and SFIs? If you're not happy to approve, therefore, could you raise a digital hand? Can't see any digital hands raised, so that's duly approved. Thank you, Katie. Can you thank whoever's done all the hard work behind the scenes? Because, you know, I know just how much effort goes into some of these, what seems to be quite small changes, but it's actually quite comprehensive. So we're then on to the board and committee dates for 2023. Our life disappears before us. Erica, anything on this you'd like to emphasise?
Nothing to add, Chair, unless anybody can see any sort of conflicts or clashes, but they have been through the committee chairs. The only thing that I'd say we wouldn't want to set in stone based on previous year's experience is the audit and the end of year board meeting.
No, absolutely. Been stung on that before. So this is on page 148, I think, of our board pack. Any questions or perspectives on the committee dates and the calendars? If you're not happy to approve, please raise a digital hand. Duly approved. And Erica, can you thank the team that's put in the effort in terms of coordinating all of that stuff as well? So I think we're then on to the safe staffing report, obviously, which will take as read. But Lucy, anything you particularly like to pull out?
Just a couple of things, if I may, Chair. So obviously fill rates have greatly improved compared to earlier in the year. We remain, as we've just alluded to in the finance section, heavily reliant on agency staff and temporary workforce to achieve those fill rates. And we've already alluded to our successful international recruitment pipeline. So if you recall, we agreed to recruit 100 international nurses by the end of December, and we're on track to deliver that. And we are still seen as an exemplar site for international recruitment. We're hoping to take advantage of a more recent offer from Health Education England to increase your international recruitment during Q4 of next year. We're hopeful to take advantage of that. Just in order to answer some of the questions that came up around reliance on agency, and when will you see the vacancy factor drop and agency spend therefore reduce? We are still, however, predicting at the end of December a 46 whole-time equivalent registered nurse vacancy factor in the frontline services. Our vacancy factor is larger than that, but in ED, theatres and our acute wards, we're still predicting a vacancy factor of 46, and that's factoring in turnover at the current rate, the recruits that we know about, the international recruits that are coming in, and hopefully being able to take advantage of that recruitment offer. So we will still be reliant on agency with a vacancy factor of 46, and we know our sickness levels are higher than the national average in the NHS. That said, the report does include the things that we're focusing on as part of the nurse agency reduction programme. And we're currently working up some performance indicators that we can pull together into one collective report to bring back to the December board, just to show where we're achieving some of the things that we have set out to do in that programme. I do just want to touch on, and Katie did already, as you know, board approved the new contract for the master vend arrangement last month, and we introduced a new rate card in September. For this month, we've been running a shadow month with the master vend agency, and myself and Jonathan, who managed that contract with the master vendor, have been looking at their achieving of the tiers of fill at the right price. And so far, that really is showing green shoots of hope. And we're certainly managing within that break glass, that tier 3 that we would hope not to use. We've still got some further work to do around reducing Thornbury and eradicating that completely. And we have, since the last board, I know it was discussed last month, engaged with colleagues within mental health services to look at reducing our reliance on registered mental health nurses. And they're going to come up with a checklist for us, and also a clinical point of contact Monday to Friday during the day where we think we need one, and they'll help us with our decision making and alternatives. Other than that, happy to take any questions.
Very comprehensive, Lucy. Any questions to Lucy? Lucy, I'm not sure whether you saw, and this is for you as well, Katie, in the HSJ there was a an article on the extraordinary increase in profits of agency companies. So clearly they are doing disproportionately well out of the NHS. We'll move on then to the quarterly patient experience reporting. If you could pick up the earlier point that Grace made, that would be great. But what would you care to pull out of this report? Obviously, take it as read. Thank you.
I will do. So there's a lot of information in the report, and as you say, you can take that as read. I think the things I'd want to highlight is we still have got to work on that backlog of overdue complaints. There are large numbers in the medical division and the surgical division, none in the integrated care division, none in clinical support specialties. The divisions have got a plan to have delivered on that backlog by the end of October, but I would caveat that with, I worry that given the pressures that we're under, that they may not achieve that end of October deadline that they're looking at. We alluded earlier, or Jane alluded earlier, to measuring our response times to complaints and coming up with a different measure to help board understand where we are against that. And we trialled that with the medical division workshop that Jane did earlier this week. So what we can say is that 75% of the medical division's complaints are responded to actually within 35 days. So they're just missing the 30-day deadline, which is within our policy. But actually the remaining 25% have taken anything from 35 days to 56 days. But we will start to express that in future reports so that that's clear to board. We have still got some work to do around the culture that we have and attitude and behaviours around the complaints process. And all too often we hear complainants saying that they were told by our staff to go to PALS. Now our staff should be trying to resolve those concerns, those complaints at source rather than directing to PALS. And clearly we need to make sure that our staff are equipped and able to deal with that. That said, I think there's lots of really good news in the complaints report. You know, we're getting less what we call comebacks, which means actually when we respond to complainants, we're getting it right first time and answering their concerns immediately. I'm really excited around the bespoke surveys that we've now developed. So we've got bespoke surveys for inpatients, for district nursing and outpatients. And those surveys do enable us to focus in and target on some of those themes that come through complaints and through the inpatient surveys. I'm really excited about the text messaging pilot that we undertook in outpatients to ask the family and friends test question. And I'm really excited that we've now extended the contract and are rolling out the text messaging to all services, so inpatients, outpatients, ED. And I'm even more excited that the second question that we're now able to do through that text message is to link the second text back to one of our bespoke surveys and invite individuals to respond to the survey, which will give us much more meaningful and timely information about their experiences. And finally, I guess I want to finish on the number of volunteers and the diversity of roles that they occupy across our services, and particularly the success of the young volunteer workforce. But more importantly, the fact that we've recruited 13 of those individuals into substantive positions, which absolutely fits in with our growing our own and showing that Wye Valley Trust and the NHS is a great place to work. To just touch on your question, Grace, around complaint response times. So I think the key to it is what we're trialling already, which is that phone call to the individual that's raising the concern or the complaint immediately to understand what they want from that. And that will be key to us not developing a backlog and not having the backlog of and the time it takes to respond. We're seeing some early shoots of success in that within surgery, in that many of those concerns are being dealt with in a timely way after that phone call, rather than entering into a formal protracted complaint process. So I think that's key. Early phone call, early contact. One size will never fit all. Some complainants want us to do the full investigation and write the letter. But I think that the improvements that we intend to make will help us not have a backlog in the future and certainly respond more timely. Thank you.
Okay, thank you, Lucy. Any questions or perspectives to Lucy? Nicola?
Yes, I was just we've made a real seismic jump in terms of some of the information we're starting to get in, some of the data behind the complaints and the structure behind what you're doing that. So I just want to say, having seen that in the last 12 months, there's loads of work within that. So thank you very much. The only thing I probably would like to see a little bit more of, I think, still with communication, that is such a huge chunk of our complaints, and I think it's such a broad subject and it's such a broad range of answers. I would love to see some breakdown further on that of what it actually means within that communication complaints data, so that I think that could give us some areas to really pinpoint the actions we take. But I just want to say thank you. I can see it's moved a long way forward.
Thank you, Nicola. Just keeping the pace going, given the time. Grace?
Thank you, Chair. Thank you, Lucy. Absolutely. As Nicola says, it's moved so much forward, and I'm really excited about the text messaging as well and getting that detail. Similar point to Nicola, firstly, in that, getting more a breakdown of under the themes it talked about behaviours and values of staff. I'd be really interested to kind of get like a sub theme, and also in the communication to see, are there any themes within these themes, and do they need to be addressed in a different way rather than simply within the complaints process? Does it indicate something outside? And also just really appreciating the impact not getting comebacks can have, I think, longer term, because, you know, if someone has a difficult experience, that could impact their relationship with healthcare potentially through their whole lives. It could mean that everything gets complex, they present later, it can have a huge impact for the system overall. So doing this is not only for patient experience, which of course is incredibly important. I would imagine it's a system impact as well. Thank you.
Thank you, Grace. Lucy, do you want to say anything on that?
No, thank you. Other than that's really helpful. I'll probably want to say one final thing at the end, if I may, but I'll let Frank come in first.
Frank, and then we'll move on to Lucy, and then we'll move on.
Yeah, thanks. The text messaging thing triggers off. Are we consciously harvesting the data, the contact data, so that we can use it for more general communications in the future? It could be really quite powerful stuff to be able to communicate with everybody that's touched the hospital. But there might be a GDPR connection or implication, I don't know, but it would be very well worth it, I think.
Certainly take that way and look at it, Frank. I just wanted to come back on communication, if I may, very briefly. I'm bringing a proposal to Trust Management Board tomorrow around our visiting arrangements for staff. I mean, clearly during the pandemic, visiting was restricted completely at times and then heavily restricted throughout the last 2 years. We're bringing a proposal to open up visiting beyond even our pre-pandemic measures, and I'm hoping that that gets supported tomorrow, because I personally and truly believe that by doing that we'll be able to engage with families, patients and their carers in a more timely way, and therefore naturally improve our communication and their understanding of what's happening to them and their loved ones.
Okie dokie. Well, exciting times, Lucy. Keep us briefed, please. Thank you very much. We'll move on then to the digital programme update. I've asked colleagues just to pull out the key points, and you, Andy, on the winter plan, so that we can pick up the pace, please. So, a digital programme update. Katie?
Thank you, Chair, and I will keep this brief. It's been a really busy period for the digital team, and I just wanted to say a big thank you to all involved in our latest significant piece of work, which was the rollout of inpatient clinical noting, which went live on the 26th of September. As we've talked about at previous board meetings, it is a significant change for many of our frontline colleagues, but I am pleased to say that early uptake and progress has been largely positive. As expected, there have been some challenges, and the implementation team have been really proactive, working with colleagues across the organisation to seek solutions to make sure that that implementation is a success, and support has been in place 24/7 over that initial launch period, and we've managed to support over 400 staff in the first 10 days. So still a long way to go to make sure it remains embedded and successful, but really, pleasing early start to that rollout. The rest of the report I will take as read. Update on the wider digital programmes, and just to say, in terms of the financing aspects of digital, we do continue to submit expressions of interest whenever funding opportunities arise to try to ensure we can prioritise more of these schemes going forward.
Okay, thank you, Katie. And David, I'll ask you, Mowbray, to come in now if you could, just because obviously the clinical noting's gone in, and I'm sure there's been a degree of turbulence. How are you feeling about things?
I've really enjoyed rolling out the reverse boarding policy and the digital noting at the same time, Russell. We've got 170.
Did you say the boarding policy?
Sorry, yeah. We've got 170 consultants. 3 to 4 have raised safety concerns, which were immediately dealt with by the team that Katie alluded to, and there are largely hardware problems. I mean, and largely not switching things on and unplugging things and what have you, but they've been dealt with immediately and effectively, I'd like to say. The rest are valiantly changing to what is a fundamentally different way of practicing medicine. I can't explain enough or emphasize enough how threatening it is to people moving from a pen to digital. We had it in GPs before, and just we need to keep listening, reacting and supporting, but we need to keep moving forward.
Okay. David, keep us briefed on that between board meetings if you need to. Katie, can you thank the team who are leading the project as well? And David, can you thank all of our clinicians for their forbearance and the positive nature with which I'm sure most of them are approaching this important change. Any questions to Katie or David? Okay, we'll move on then to the winter plan, and again we'll take the documents as read, but what would you care to pull out, Andy?
Yeah, thanks, Chair. I'll pick up the main points. You say the presentation's in your pack. Just to the concept of our winter plan this year was to address the 5 key areas of harm, and that's harm to patients waiting for ambulance in the community, harm for patients waiting for an ambulance, waiting to offload of an ambulance in our ED, patients waiting in our ED for a timely assessment and treatment, which at Hereford we are pretty good at and one of the best in the country in terms of that element of harm. Harm for patients waiting a considerable time for ED, and that's probably for us is a trust internally one of our biggest areas of harm, and also our harm in terms of patients waiting to be discharged and the risk of hospital acquired functional decline. So that was the sort of key areas of our winter plan. The ICS winter plan is still awaiting final sign-off. We met in the summer as a place-based system with all our key providers, Taurus, our Health and Care Trust colleagues, the Hereford Council and Powys Health Board to develop this plan. Just to quickly run through some of the main points of our plan. So firstly, it's around improving our community and place-based schemes. So one is our integrated community integrated response hub. So we've already amalgamated our district nursing hub with our CIRA team. That's increased our operating hours for referrals for district nursing. We've just implemented our ability for our CIRA team to pull 999 calls waiting on the ambulance command and control system stack to enable us to respond our community teams out to those patients with community and frailty teams rather than waiting for an ambulance response. And that's just started, and that is work in progress as we head into the winter, along with our CIRA team just getting funding for an end-of-life coordinator who should be able to support an end-of-life urgent response in onward referral through our CIRA team. We've also worked with Taurus around enhancing our virtual GP support to our urgent community 2-hour response team, and our hospital at home team as well has increased their capacity over the winter period to increase our outpatient antibiotic therapy and increase our discharge capacity, and also increase our MNAB service for medication for our vulnerable COVID patients. We've also currently working with YMAS around how we manage acute respiratory infections in the community, and offering support and guidance to ambulance crews who respond to patients who are at risk of respiratory infection, and how we can manage those through our community teams or onward support and guidance through secondary care consultants. And we're also looking at implementing a virtual ward. Now, that is support for patients who would otherwise be in hospital to receive acute care monitoring support at home for approximately 20 to 25 beds by January 2023. These patients will be referred to our virtual ward team via a coordination hub, who would otherwise would have been admitted to hospital or would remain in hospital and will obtain early discharge support through the use of remote monitoring and daily multidisciplinary team ward rounds with acute physicians, community teams, primary care, and a response, if required, from face-to-face teams in the community. We're also looking at an increase to our urgent responsive 2-hour response through support from our acute and frailty pathways, and looking at how we can improve our therapy provision in the community through diverting away from some of our community hospital resource that otherwise don't require a therapy input. In terms of the acute site, we've already mentioned our discharge coordinators. We've got increased, we're keeping open our escalation beds on the 2nd floor, and we're also increasing our acute site frailty pathway support through our frailty SDEC, but also, as we've already alluded to, an increase in the frailty geriatricians. 2 new frailty geriatricians have joined the team, and that increases our offering to the acute floor and our front door frailty team. We're also working through our modern ward round and our 100-day discharge challenge, and we've already mentioned ensuring we implement our proactive flow SOP and making sure our surge plans are match ready. In terms of the command and control structure over the period, there are national, regional and local command centres in place. There is comprehensive reporting and cascade of information from national to local teams, and then local teams back up to national teams. We're looking to implement our what's called SROOD in December, and that is a local and regional view of demand and capacity across providers and visibility of pressure across the system to inform decision making, along with our well-rehearsed and well-established gold and silver coordination meetings across the week with system partners. In summary, will this get us through winter? It will help, but this winter will be challenging and has already started. How challenging is unclear, but if the past few weeks are an early indication, it is likely to be significant. But what we can rely on is a trusted and responsive partnership in Herefordshire and the flexibility and commitment of our teams.
Okay, thank you. Very comprehensive. Questions and perspectives, Frank?
Yeah, I'm interested in exploring. I mentioned this morning, Andy, the virtual ward thing. I mean, it's really quite an exciting concept, and if we could grow it, wouldn't it be good? But I'm concerned that I don't understand how we're going to handle the logistics of it, the connectivity, the hardware that's needed, the installation of it in an appropriate way, and then recovering it when it's finished. All of that sort of stuff. I don't know whether you've got any research papers or whatever that you've done, but if you could share offline, I'd be grateful. Thank you.
Yeah, happy to, Frank.
I think, Frank, as we said this morning, we'll have a workshop session on it, so all Ned's feeling up to date on it. But if there's anything that can be pre-circulated, Andy, that would be good. And Andrew?
Yeah, in our smaller group on the strategy day we had, the one issue that emerged to the top of the pile, if you like, was getting dom care right, or getting recruitment into social care, basically. John was in our group, and that emerged as the sort of #1 priority, really. I wondered where we were in terms of getting social care support around this plan.
Okay, great question, Andrew. Thank you. Jane, do you want to come in on that?
Yes, there's a number of things, and I say, and I think, as Andy said, I mean, this is a plan that really is a system-wide plan. It's about how all the partners work together, as well as the things that we can do. So obviously the home first element of this is something that obviously we've been working at together for quite some time, and it's definitely made an improvement to retention of those staff, and recruitment is clicking up, so it's about half the number of vacancies. What Hoople have done now is, with our encouragement, they're now going to agencies. So I think the first 4 agency staff started last week, so they're now using some agency staff for that, but also they are filling in for where home care is failing. So they're just keeping people on their books for longer. So Home First is going to have to sort of grow and grow and grow, I think, to be able to continue to deliver that. In terms of the national monies, the £500 million that's coming out, some of that's going to be dedicated towards social care workforce, and pretty much that's going to be some retention payments. So that's what the council are doing at the moment. They're looking at how they can work with providers around supporting retention of staff by some financial incentives. So they're doing the detail on that at the moment, and we'll bring it back. And then the other part of that will be around capacity. So it'll be things like block booking of nursing home beds, that sort of thing. But yeah, we know that there are a lot of nursing home beds vacant in the county, but they're vacant because they can't get the workforce to fill them. So again, it all comes back to workforce. Well, I think I would say is, I mean, they're really engaged. We're doing this together. They're really open. They're not doing it in a closed way. They're open to challenge and different ideas. But that still isn't going to solve the fundamental workforce problem that we've got.
Okay, thank you. Comprehensive answer. Keep us brief, Jane, and then Ian, and then we'll move on.
Yeah, I mean, this is not the main issue, but I was just pondering whether part of the £500 million, and given the workforce challenges there are in social care, whether there's any scope for voluntary sector support for people who may not actually need care, but it's those who sometimes need some practical support. Somebody there when they get home, somebody to get some shopping in, make sure that the heating's on. And I'm sure we've thought of all of this, but it's just whether or not there are some other ways we could use that money in more flexible ways, which may not be our main challenge. But if we can support some of those Pathway Zero, if that's what they are, people, it makes some of our other challenges a bit easier as well.
Yeah. I mean, it's through the Talk Communities Network, and there's more we can do. I mean, I think it's the infrastructure's there, but there's an awful lot more that can deliver. I don't necessarily even think it's a money issue. It's more around growing those community networks. I think sometimes there is an overstatement of the amount of difference that would make. The Red Cross for a number of years have been saying we'll provide this service, and actually the number of people who really need that is very tiny. Generally we would be discharging them anyway. It'll make it a better discharge, but it doesn't really help flow that much, I would say, in my experience.
I think the other thing is I think we're still waiting for confirmation how much exactly is coming and how the money is going to flow, and we're in October before we know it. And so this money always arrives very, very late in the planning cycle, and then it's very difficult for organisations to sort of come up with solutions, and before you know it, we're in December. So there needs to be much better forward planning. Guys, we're now running very late because we seem to be taking a long time over papers. So I'll allow Glenn to come in, and can we get back and try and pick up the pace? Glenn? Yeah,
I was just going to add, I mean, there are, as I see it, as Russell says, we don't quite know what the allocation will be locally yet, but it will be quite permissive about making general improvements to any pathways of discharge. So Pathway Zero would be included within that. I mean, there's some good examples. The Warwickshire Fire and Rescue Service actually provide a really good getting people home model as well. So I think we should look at that end of the spectrum. You're quite right, Ian.
Yeah. Okay, great. So we'll move on then to the Audit Committee report for the 15th of September. Andrew.
Take it as read, nothing to add, Chair.
Okay, any questions or perspectives on the Audit Committee minutes of the 15th of September? Okay, so we're then on, thank you, Andrew, to the Charity Trustee minutes from the 15th of September. Frank?
Nothing to add, Chair, thank you.
Okay, thank you, Frank. Any questions or perspectives to Frank? And so we'll move on then to the Integrated Care Executive from the 12th of September. Francis?
Thank you very much, Russell. Only really just for members of the public, we are continuing to try and make our services as joined up as possible, and really positive moves that access to urgent district nursing services are now linked into the 2-hour community response, and all of these things should enable us to use our resources better, and also for professionals and other people to be able to contact us simply. So some really good progress in regarding One Herefordshire as a single workforce aligned around a single assessment, care and support plan for people.
Okay, thank you, Francis. Any questions or perspectives to Francis? Okay, great, thank you. So we'll move on then to the Foundation Group Sub-Strategy, I think it means Foundation Group Strategy Subcommittee of the 30th of August, which I'll take as read. Any questions on those minutes? Okay, super, thank you. So the Quality Committee, the 25th of August, Ian. Oh, I apologise, Lucy. Did you want to come in on the last set of subcommittee minutes?
I was probably premature. I was going to raise a point on the Quality Committee minutes when Ian spoke, and sorry, but I'll wait for Ian to...
Ian, so Lucy's going to ask a question in a minute, but you go.
I had nothing to add, Chair, but I'd like to bring Lucy in.
Lucy, any questions or perspectives? Lucy?
It was just to note, because the paper alludes to the maternity continuity of carer plan that was discussed at Quality Committee. It's just to update board and members of the public that since that meeting, there's been a national announcement that the target and trajectory for continuity carer as a model has been removed, and plans are for local determination where workforce allows. Thank you.
Very wise. Thank you for that. Expansion, Lucy. Any questions on the Quality Committee minutes or Lucy's addition? Okay, super, thank you. So I think then we are on to any other business. Any other business, colleagues? Please raise a digital hand. Okay, team, that brings the end to this public board meeting. I hope members of the public who might be watching it find it useful. I don't think we've had any questions from members of the public, have we, Erica?
No, Chair.
But members of the public are always very welcome to send us questions in advance. In the meantime, Andy has very clearly outlined with Jane's introduction the operational challenges we're facing at the moment at the Trust. The way members of the public can help us, their loved ones and their communities is by having a flu jab and having the COVID jab when offered to you. Don't be afraid to wear a mask out in public, particularly if you're feeling under the weather. Continue to wash your hands more thoroughly than pre-pandemic you might have done, and take care. We all need to look after one another at the moment. And to our frontline teams, just to say an enormous amount of thanks from every member of the board for the continuous efforts you make to look after the people of Herefordshire. For my board colleagues, we'll take a 5-minute break and then we'll get back together again at 3:25 for the confidential board. See you then. Thank you.